On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for the CMEO snacks entitled Mechanistic Rationales for Novel and Emerging Treatments for Psoriatic Arthritis, Plugging the Data into the Equation. This activity is supported by an unrestricted educational grant from Bristol Myers Squibb Company. I'm Alan Gabowski, Professor of Medicine at Weill Cornell Medicine, attending rheumatologist and co-director for the Clinic of Inflammatory Arthritis at Hospital for Special Surgery in New York, New York. I'm joined today by my dermatology colleague, Dr. Anthony Fernandez. Dr. Fernandez is the Director of Medical Dermatology and the W.D. Steck Chair of Clinical Dermatology in the Departments of Dermatology and Pathology, the Dermatology and Plastic Surgery Institute of Cleveland Clinic in Cleveland, Ohio. Welcome, Tony.
Thank you, Alan. It's a pleasure to be here.
Today's activity is eligible for ABIM maintenance certification credit and also as a CME for MIPS improvement activity. If you want to claim ABIM maintenance of certification credit, be sure to fill in your ABIM ID number and date of birth on the evaluation so that your credit can be submitted directly to ABIM. And if you want to claim the activity for CME for MIPS, over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation. Complete the follow-up survey from CME Outfitters that you will receive in approximately 3 months. And then CME Outfitters will send you confirmation of your participation that you can submit to CMS, attesting to your completion of the CME for the MIPS improvement activity. Our learning objective today is to assess the mechanistic rationale for novel and emerging treatments for psoriatic arthritis, including key clinical efficacy and safety data for targeted treatments. So, Tony, let me ask you to start off with a brief overview of psoriatic arthritis.
Sure, I'd be happy to. As you know, psoriasis is a common chronic immune-mediated disease. And in its moderate to severe forms, we really recognize psoriasis as a systemic inflammatory disease, and patients are at risk for developing numerous comorbid diseases. And the most common of those comorbid conditions is psoriatic arthritis. Psoriatic arthritis is a seronegative inflammatory arthritis that is estimated to affect about 30% of all psoriasis patients at some point during their disease course. And Alan, as you know better than anyone, psoriatic arthritis can have really debilitating effects on patients' lives. It can cause permanent damage to peripheral joints, the spine, different tendon insertions, the fingers, toes, and can impair physical function from that point on if permanent damage is done. And luckily, although management of psoriasis has improved, we do not have a complete understanding of the pathogenesis of psoriasis, nor do we have medications that can completely control the inflammation associated with psoriatic arthritis. However, over the past several decades, we have learned a lot about the pathogenesis of psoriasis and psoriatic arthritis, and hopefully that will help lead to better treatments in the future. Alan, can you tell us a little bit about our current understanding of the pathogenesis of psoriatic arthritis?
Well, the overriding hypothesis for this disease, as well as many others that I see and you see, is that disease occurs in genetically susceptible individuals who encounter a particular environmental trigger or perhaps multiple triggers. We've teased out a lot about the genetic susceptibility, and we're still learning about what potential environmental triggers may be. So if we look at psoriasis as the area where the disease begins, then we have a variety of changes in the skin, in the composition of the cells of the skin, in the regulation of the layers of the skin by various cytokines such as interleukins and interferons and tumor necrosis factor. We have the involvement of bone marrow-derived cells, and we're learning much more very recently about the potential impact of the microbiome of the gut in imprinting cells that may be exposed to it and then affecting disease manifestations in other parts of the body. In psoriatic arthritis, we're concerned about domains such as the joints, of course, but also extra-articular domains such as the enthesis, which is where tendon and ligament insert onto bone. We believe that the mechanisms at the cellular and subcellular level are also active in the joints and at the enthesis. At the enthesis, the biomechanical stress or trauma may cause interleukins such as IL-23 to affect type 17 lymphocytes, with further involvement of other interleukins and tumor necrosis factor, leading to osteoblast and osteoclastosis and the impairment of the tendon where it inserts onto bone. Within the joints, we have a carefully calculated orchestration of numerous cells, such as the antigen-presenting dendritic cell, the macrophage, the activated lymphocyte, the synoviocyte, all of which, under the influence of interleukins and cytokines, may result in bone destruction and the ultimate clinical manifestations that we see. And the reason that these various cellular mechanisms and cytokine influences are important is that as we begin to understand their interactions more, they provide us with some interesting targets that can be used as therapy in this disease. Tony, speaking of targets and speaking of therapies, can you briefly review some of the therapies that we use for psoriatic arthritis?
Sure, Alan. There luckily are a number of options that patients can be offered for psoriatic arthritis, and many of these are also approved for the treatment of cutaneous psoriasis. So first of all, there are a number of non-pharmacologic therapies that patients can be offered. For example, physical therapy or exercise therapy, massage therapy, and then also addressing different lifestyle choices which may promote joint pain or joint swelling or inflammation, such as smoking cessation, diet, and weight loss. All of those can have some positive effects on patients' disease. But of course, there are a number of pharmacologic agents that are now available to offer these patients. There are symptomatic treatments such as NSAIDs or intra-articular corticosteroid injections when just a few joints are involved. There are oral small molecules that can be offered to patients, traditional DMARDs like methotrexate or sulfasalazine, and newer small molecule inhibitors like apremilast. And then a number of biologic medications, the TNF-alpha inhibitors, of which there are 5 that are currently available, one IL-12/23 inhibitor, ustekinumab, IL-17A inhibitors, secukinumab and ixekizumab. There are now IL-23 inhibitors available. Guselkumab is one that is already approved by the FDA for treating adult patients with psoriatic arthritis, but there are currently trials going on with risankizumab and tildrakizumab. There's a CTLA-4 inhibitor, abatacept, which is specifically approved for psoriatic arthritis, not psoriasis. And there is one JAK inhibitor that is currently approved, tofacitinib. But interestingly, there are a number of agents that are being studied right now that function by blocking different components of the JAK-STAT and TYK2 pathways. And Alan, personally, I think the JAK-STAT pathways are particularly interesting in their roles in psoriatic arthritis, as are the medications that are currently being studied that focus on that pathway for treating psoriatic arthritis. Would you agree with that?
Oh, most definitely. These agents are the most recent and probably the most interesting in our current therapeutic armamentarium for psoriatic arthritis and other rheumatic diseases as well, where there are established uses as well as investigational uses. Let me take a minute and just briefly review the JAK-STAT pathway in psoriatic arthritis, which will serve as a model for understanding the JAK-STAT pathway in any of our diseases. Fundamentally, when a cytokine is recognized by its receptor, then intracellularly, there is a molecule called Janus kinase, which is what JAK is short for. And when Janus kinase is activated as a result of the dimerization of the receptor by the recognition of the cytokine, then it becomes phosphorylated, and phosphorylated JAK then binds another molecule called STAT, signal transduction and activator of transcription. This activated molecule then goes to the nucleus under genetic control, leading to the production of inflammatory mediators and augmenting the cycle of inflammation. And so one of the ways that we can inhibit this cycle is by interfering with the receptor or interfering intracellularly with activation of the JAK pathway. So the JAK inhibitors that you've mentioned work by inhibiting the JAK pathway, by inhibiting JAK intracellularly, thus preventing the activation of STAT and the downstream activation and formation of more mediators of inflammation. Now, the first Janus kinase agent that was approved for the treatment of psoriatic arthritis was tofacitinib. In fact, it was the first Janus kinase approved for the treatment of a rheumatic disease, initially for rheumatoid arthritis and then for psoriatic arthritis in combination with methotrexate. And what you see here are the results of two studies, the oral psoriatic arthritis study Broaden and the oral psoriatic arthritis study Beyond, the long-term extension, where tofacitinib at 2 doses were studied. Only the lower dose is approved for the treatment of psoriatic arthritis. And you can see the comparison of the 20% level of improvement, the 50% level of improvement, and even the 70% level of improvement in the joint response to tofacitinib, a JAK inhibitor, in these patients with psoriatic arthritis. There's no such thing as a free lunch, Tony, so we also have to consider the flip side of efficacy, which is safety. And in both OPAL Broaden and OPAL Beyond, there were adverse events, both to be expected and also serious, meaning that led to hospitalization and parenteral medication. Perhaps the one that was identified early from our knowledge in rheumatoid arthritis was herpes zoster infection, seen more frequently in patients on tofacitinib than patients on placebo. But we have come to recognize the spectrum of adverse events in psoriatic arthritis from our knowledge of the spectrum of adverse events in rheumatoid arthritis, and there really does not appear a significant difference between them in terms of the manifestations of tofacitinib seen in the RA clinical trials versus the psoriatic arthritis clinical trials. Upadacitinib is another agent that has been approved for the treatment of rheumatoid arthritis, currently being studied for psoriatic arthritis, again at 2 doses, but only the lower dose has been approved for rheumatoid arthritis. And what you can appreciate is that when upadacitinib was given, it did better than placebo in the studies to demonstrate its efficacy that will be reviewed by the FDA. As might be expected, there were adverse events with upadacitinib as well. Same spectrum, same comparators, same types of agents and adverse events seen, in particular the increase in herpes zoster. Perhaps the newest agent that we have that's in investigational studies is a closely related molecule to the Janus kinases called deucravacitinib, which is a tyrosine kinase. It is a member of the Janus kinase family, but slightly distinct from it. And here in this study of deucravacitinib at 16 weeks, you can appreciate significant changes in the ACR 20, 50, and 70 in patients taking deucravacitinib versus placebo. As might be expected, there's no such thing as a free lunch for deucravacitinib either, because there have been adverse events noted in these trials as well. And the FDA does require display of adverse events occurring in more than or equal to 5% of patients, as can be seen.
Alan, that was an excellent overview of the current and emerging agents for psoriatic arthritis. So my takeaways from this are that it is important that we as clinicians first evaluate the mechanistic rationale for novel and emerging treatments for psoriatic arthritis, and that we assess the efficacy data and the safety data for current and emerging JAK inhibitors to determine their role in the management of psoriatic arthritis.
Excellent goals to have in order to make good treatment decisions for our patients. And I again tell our audience in conclusion that this CMEO snack is one of a 3-part series, and we hope you'll take advantage of viewing all of them, since they're all short and focused and build on each other to give you additional information about patients with psoriatic arthritis. Now, these activities and a wide variety of other activities and resources on inflammatory disorders are available on the CME Outfitters Psoriatic Arthritis Education Hub for both healthcare providers and patients. To collect credit for this activity, click on the link to complete the post-test and evaluation online. Be sure to fill in your ABIM ID number and date of birth on the evaluation so that CMEO can submit your credit to ABIM, and you can print your certificate or statement of credit immediately. Well, thank you, Tony, and thank you, audience, for joining us today. I hope the presentation gave you some new ideas and treatment strategies for use in your patients with psoriatic arthritis. It may be initiating treatment, it may be referral to a rheumatologist or to a dermatologist, but the important step that we hope you'll take away is to act, and to act early in order to mitigate joint damage. Thank you.